Assalamu alaikum, it's me, Dr. Muhammad Qazafi. You are watching Dr. Muhammad Qazafi Views, where there is a morning, there is a good morning, and where there is a evening, there is a good evening. I want to present one topic which is called the optic nerve decompression with the analogy of one case, such as a metaphor of one case, and it is a real case. All cases what we are presenting, it's a real case. There is a 35-year-old female presented for her 1 month follow-up after the orbital optic nerve sheath fenestration for malignant pseudotumor cerebri syndrome. Her incisions are healing well and her orbital edema is resolving and her eye movement are full. However, her visual field appeared to be worsening despite the apparent improvement of her optic nerve edema clinically and by optical coherence tomography. She continued on the 500 milligrams of peroral acetazolamide twice a day but continued to have a headache with pulsatile tinnitus. What is the most likely cause of her symptom despite the improvement of the edema? Actually, yes, the most likely, I think, cause of her symptom despite the improvement of her edema, there is a continued intracranial pressure elevation and causing optic nerve compression and axonal loss, producing optic nerve atrophy or optic atrophy, and the rate at which the optic disc edema resolve after treatment depending upon the length and the severity of the preoperative perioptic intracranial pressure and the method of the intracranial pressure lowering. However, improvement in disc edema can represent either reduction of the exoplasmic stasis or continued axonal loss from the persistent intracranial pressure elevation. It is important to check visual field and visual acuity at each postoperative visit. In addition to examine the optic nerve for the status of the edema, patient with an improvement of the disc edema from intracranial pressure lowering should demonstrate and the visual acuity stability, while those with continued optic nerve damage will demonstrate a decline of their visual function. Signs of the continued intracranial pressure elevation after optic nerve sheath fenestration include continued headache, transient visual obscuration, and cranial nerve 8 palsies with associated diplopia. An important sign of continued intracranial pressure evaluation is causing a reduction in the optic disc edema from axonal loss is the development of the optic atrophy. These patients should be strongly considered for the cerebral spinal fluid diversion procedure for global intracranial pressure control. So, my topic definitely is the optic nerve decompression. I want to put little light over this topic because this topic requires some attention, and I want to extend my lecture in that manner that the optic nerve sheath decompression, more commonly known as optic nerve sheath fenestration, is a surgical procedure performed to decompress the optic nerve by creating a window into the optic nerve sheath to release CSF from the subarachnoid space around the optic nerve, and it is performed to alleviate vision-threatening papillar edema or swelling of the optic nerve in the setting of elevated intracranial pressure. This procedure is generally done for patients with pseudotumor cerebri, a condition associated with elevated intracranial pressure and papillar edema, or patients with the progressive vision loss that are non-responsive or non-adherent therapy So this lecture, the purpose of this lecture present, we should know the causes of the papillary edema and how to, I want to describe the role of the optic nerve sheath fenestration in preventing progressive vision loss in the setting of the elevated intracranial pressure, and I want to describe the potential complication of the optic nerve sheath fenestration, and simultaneously I want to explain the importance of improving care coordination among interprofessional team members to optimize outcome for patients with optic nerve compression. As you know, the optic nerve sheath decompression, more commonly known as the optic nerve sheath fenestration, is a surgical procedure performed to decompress the optic nerve and relieve vision-threatening papillary edema in the setting of the elevated intracranial pressure, and performance of this procedure is generally in case of the pseudotumor cerebri syndrome, where patients are rapidly losing vision from significant elevated intracranial pressure, or in case of the progressive vision loss in patients who do not respond to the medical therapy or non-adherent with therapy. The exact mechanism by which fenestration is spaced with filtration of the cerebrospinal fluid out of the subarachnoid space through the dural opening, as well as scarring of the surgical site that prevent further accumulation of CSF, are felt to be contributing factor. So the optic nerve sheath decompression does not treat the source of the elevated intracranial pressure but the procedure does diminish the associated visual sequelae. So the anatomy and the physiology for the related topic is very important. As you know, the optic nerve is distinctive among all other cranial nerves in that it is the central nervous system by itself, white matter tract, that shares a similar developmental origin with central nervous system. As such, the optic nerve covering is the same outer connective tissue membrane as the brain, the pia, the arachnoid, and the dura mater. The pia lies on the surface of the brain and follow along the brain gyri and sulci. The arachnoids matter lie just above the pia mater, and the CSF flow in the subarachnoid space between the pia and subarachnoid matter. The dura mater is the strongest connective tissue covering that overlies the other arachnoid and the pia mater and encasing the brain and the spinal cord. The subarachnoid space of the optic nerve is contiguous with that of the brain via suprasellar cistern, and allowing the circulation of CSF between the intracranial subarachnoid space and the optic nerve in a three-compartment system. As a result of increased intracranial pressure can be transmitted to the optic nerve and can cause optic nerve edema, known as in this clinical setting as papillary edema. So the optic nerve sheath fenestration is a surgical procedure performed to relieve perioperative pressure in case of elevated intracranial pressure causing papillary edema. The subarachnoid space of the human optic nerve is not homogeneous but possesses a complex system. If subarachnoid and the arachnoid trabeculae and septa that subdivide the subarachnoid space between the arachnoid and the pia mater, the trabeculae, septa, and the pillars vary in their density as well as their arrangement depending upon the specific location within the different portion of the optic nerve. They appear to be more densely and tightly packed in the immediate retrobulbar segment of the optic nerve than the more distal mid-orbital and canalicular segment. This variability may play a role in the CSF dynamics between the subarachnoid space of the optic nerve and the suprasellar cistern that connect it to the intracranial space, and may contribute to the understanding of the pathophysiology of papillary edema and the sometimes variable response seen to optic nerve surgical fenestration. Indeed, increase in intracranial pressure can result from the multitude of central nervous system disease status includes intracranial hypertension, venous sinus thrombosis, central nervous system infection, inflammatory disease, subarachnoid hemorrhage, and intracranial malignancy or other lesion causing obstructive hydrocephalus. So the vision loss in the setting of the papillary edema is thought to occur as a result of disruption of axonal transportation and intraneuronal ischemic damage to the optic nerve. An increase in the cerebrospinal fluid retrolaminar pressure. This results in defective axonal transport, followed by the intraaxonal swelling, which is seen as papillary edema. This swelling can secondarily compress small arterioles to the nerve and consequently causing intraneural ischemia. Clinically, this manifests as a vision loss, initial as blind spot enlargement and followed by the loss of peripheral and then central vision and the field loss. Ultimately, optic nerve atrophy ensues in the setting of the chronically elevated intracranial pressure and papillary edema, often with profound vision loss. Indication for the optic nerve surgical fenestration. As stated earlier, the indication for the optic nerve sheath fenestration is in the setting of the vision loss due to the elevated intracranial pressure causing papillary edema. So the increased intracranial pressure can result from the multitude of the central nervous system disease states. The most common of these include the PTC syndrome, or we can say the cerebral venous sinus thrombosis, or the intracranial tumor causing intracranial pressure elevation from decreased CSF outflow. So other less common and historical indication also discussed at well. But as you know, the pseudotumor cerebri syndrome or the idiopathic intracranial hypertension is an indication for the optic nerve sheath fenestration, is the most frequent in the setting of the pseudotumor cerebri, also known as the benign intracranial hypertension. It is a syndrome of elevated intracranial pressure in the absence of an underlying central nervous system pathology. Idiopathic intracranial hypertension is a subset of the pseudotumor cerebri syndrome in which no secondary cause such as the transverse sinus stenosis or thrombosis or venous sinus thrombosis or corticosteroid use or hormonal abnormality is present. So it is no secondary causes are there in pseudotumor cerebri syndrome. So the increase or we can say the idiopathic intracranial hypertension most commonly present in women of the childbearing age who are obese or have recently gained weight, and the patient commonly present with the symptom of the elevated intracranial pressure include headache and the pulsatile tinnitus, as well as the visual symptom of the transit visual obscuration and diplopia from unilateral or bilateral cranial nerve palsies of especially the fourth cranial nerve or sixth cranial nerve palsy. Severe visual loss from progressive field construction is typically a late finding associated with significant elevated intracranial pressure and can lead to the blindness in the 5% of patients. Non-invasive treatment measures include weight loss, acetazolamide, and furosemide. Diagnostic criteria for the increased idiopathic intracranial hypertension in adults and children were revised in 2013 by Friedman, and definitive increase in idiopathic intracranial hypertension will exhibit the following things such as the papillary edema, normal neurological exam except for the cranial pathologies. Neuroimaging will show one or more of the following typical female patient with obesity. MRI will show normal brain parenchyma and no meningeal enhancement without hydrocephalus or mass or any structural lesion. Other type of the patient such as the normal MRI and the magnetic resonance venography. If MRI is unavailable or unobtainable, then CT imaging may be an option. Normal CSF composition, elevated opening lumbar puncture pressure of greater than 250 mm of CSF in adult and greater than 280 mm CSF in children, or 250 mm CSF in non-sedated or normal weight child. If papillary edema is not present, idiopathic intracranial hypertension can be diagnosed if 2 to 5 of the above are present, if it also unilateral or bilateral, and 6 cranial nerve palsy, and if both papillary edema and 6 cranial nerve palsy are absent, it is suggestive for the idiopathic intracranial hypertension, but not positively diagnosed. If 2 to 5 of the above are present and the patient have at least 3 of the following on neuroimaging, so the empty-sella flattening of the posterior globe and distension of the optic subarachnoid space with or without tortuous optic nerve or transverse sinus stenosis. Optic nerve sheath fenestration is an attempt to preserve visual function in patients with the pseudotumor cerebri who present with the vision threatening papillary edema or who have not responded adequately or cannot tolerate maximal medical therapy. It is an essential tool in an acute setting for patients presenting with the malignant pseudotumor cerebri, extremely high opening pressure, evidence of the optic neuropathy, and a poor prognosis if treated with medical therapy alone. So the serial lumbar puncture are not recommended to reduce intracranial pressure in this clinical setting, giving a rapid reaccumulation of CSF and return of the elevated intracranial pressure. So the CSF diversion procedure in the form of the ventriculoperitoneal shunt or the lumboperitoneal shunt can also be used to decrease the intracranial pressure. While they can be effective at reducing papillary edema and preventing visual loss, there is a attendant risk of brain and the spinal cord and not uncommon complication of shunt failure. Optic nerve sheath fenestration and CSF diversion procedure may both be necessary for patients with malignant pseudotumor cerebri syndrome, as well as those with the severe vision loss and intracranial pressure elevation in pseudotumor cerebri refractory to conservative management. Unilateral optic nerve sheath fenestration can result in papillary edema resolution in both eyes. However, in most cases of the severe papillary edema and visual loss and bilateral optic nerve sheath fenestration is required. A review of the unilateral optic nerve sheath fenestration shows that the unfenestrated eye typically shows less papillary edema reduction than the operative eye. Some patients may also experience an improvement in their headache, but the optic nerve sheath fenestration is not primarily for this indication, and the repeat optic nerve sheath fenestration may be necessary on patients with recurrent visual disturbance or further visual deterioration after surgery, and ventriculoperitoneal shunt is preferable in most cases in this setting. However, the scarring of the optic nerve sheath from prior surgery make repeat fenestration and more technically challenging, and there is a potentially higher risk of the complication. The other indication for the optic nerve sheath fenestration is the cerebral venous thrombosis or stenosis, obstruction of the venous drainage from the cerebral venous system secondary to the thrombosis or stenosis can result in increased intracranial pressure and papillary edema from decreased cerebrospinal fluid outflow. The condition may present very similar to the pseudotumor cerebri and increase or idiopathic intracranial hypertension, but tend to have a more rapid onset and more severe visual loss from significant intracranial elevation. It is not limited to the demographic of pseudotumor cerebri syndrome and should be suspected in non-obese women or men with symptoms and signs of the pseudotumor cerebri syndrome. It presents with patient with the prothrombic state, including pregnancy, oral contraceptive, factor 5 laden mutation, factor 12 deficiency, GTO21OA mutation, antithrombin 3 protein S deficiency. Therapies include anticoagulation, stenting, thrombectomy, or cerebral sinus and CSF diversion procedure. Optic nerve sheath fenestration and can also be performed to protect visual function in patients with the vision-threatening papillary edema, and the European Federation of the Neurological Sciences, the EFNS, in 2010 guideline appropriate optic nerve sheath fenestration in case of serial lumbar puncture, acetazolamide, or ventriculoperitoneal shunt do not prevent the progression of the vision loss in these conditions. Intracranial mass. Sometimes intracranial mass tumor create increased intracranial pressure primarily by restricting the flow of the CSF through the ventricle, or the outflow of the CSF and blood flow from the brain via the dural venous sinuses, and the optic nerve sheath fenestration is viable option of the patient in whom intracranial pressure develops rapidly and cause profound vision loss, and in whom a complete resection of the mass is not possible with resulting persistent intracranial hypertension, and performing optic nerve sheath fenestration can dramatically increase the quality of life in these patients by preserving their vision of all indication of optic nerve sheath fenestration. This has the poorest visual prognosis, as the surgery is generally a therapeutic option in late stage patient with intracranial illness. Other indication for the optic nerve sheath fenestration, like the cryptomeningitis, up to 40% of the patient develop ocular disease. Papillary edema is the most common manifestation of the central nervous system infection and may result in profound visual loss for patients who survive. Cryptococcal meningitis usually results in a very high organism burden in CSF and marked inflammation. This leads to increased intracranial pressure from the possible aggregation of cryptococcal capsular polysaccharides and the resulting CSF outflow obstruction through the arachnoid granulation, and by some physician, consideration of only optic nerve sheath fenestration is essential to avoid visual impairment, and it is reasonable consideration to practice caution before performing invasive surgical procedure in an infective optic nerve. However, studies show that the post-operative orbital infection had not occurred even when the histopathological studies revealed numerous cryptococci, and this is true even the optic nerve sheath fenestration take place before antifungal medicine administration. So the studies have shown that the patient with the papillary edema from cryptococcal meningitis should be considered for the optic nerve sheath fenestration early in the course, even if the infection is at an active stage. So the local disease of the optic nerve, such as the traumatic optic neuropathy, this can cause elevated intraocular pressure, intraorbital pressure. It commonly manifests early as an optic nerve hematoma, and the treatment of the traumatic optic neuropathy is controversial, and the large prospective study showed no difference outcome whether treatment of the traumatic optic neuropathy was with observation, corticosteroid, or optic nerve decompression. Optic nerve tumor, the most common optic nerve tumor are the gliomas and the meningiomas, and the visual improvement with optic nerve sheath fenestration in patient with the meningioma has mixed results in the reported case. Other optic nerve tumor include having the visual improvement after the optic nerve sheath fenestration include bilateral infiltration with the T cell, non-Hodgkin's lymphoma, and metastatic breast cancer. Optic nerve drusen. This may be uncommonly cause central and the peripheral visual loss through an unknown mechanism. A few small studies showed that the improvement in the management of the visual loss via optic nerve fenestration and sheath fenestration. To date, no clear recommendation exists on the treatment of optic nerve drusen with the optic nerve sheath fenestration. Further studies are warranted for this. Contraindication: optic nerve sheath fenestration should not be performed in patient on chronic anticoagulation due to the attendant risk of the bleeding into the orbit, and the procedure should typically be avoided in patient with the central nervous system infection due to the potential for seeding of the orbit with the infection organism. It is typically not performed in patients with mild or moderate vision loss related to the intracranial pressure evaluation, as they should receive a small trial of medical therapy prior to the consideration of the surgical intervention, while headache relief can result in up to 50% of the patient, and it is not indicated for the management of the headache in patient with the pseudotumor cerebri syndrome and patient with the intracranial pressure elevation without optic disc edema or visual loss. Technique is very important. There is a surgical approach. De Wacker was the first to describe the optic nerve sheath fenestration in 1872, and there are several surgical approaches for assessing the orbit for fenestration of the optic nerve. However, final goal is to create a window or a series of the slit in the optic nerve sheath just behind the globe to release CSF under pressure, causing compression of the nerve. Ophthalmologists typically perform the surgery after training in orbital surgery or neuro-ophthalmology based on a 2015 survey of ophthalmologists who performed the optic nerve sheath fenestration. The three most commonly utilized surgical approaches are the medial transconjunctival approach, about 60%, and the supromedial lid crease incision in 30%, and the lateral orbitotomy 10%. So the most people are using out of three, the medial transconjunctival approach, and the choice of the surgical procedure employed in surgeon specific depend upon the individual surgical training and comfort level with their chosen technique. All procedures are performed under general anesthesia, and the magnification either with loupes or the surgical microscope. Surgical preparation and draping should take place in the usual fashion. For the ophthalmic and a plastic surgeon, avoidance of the injury to the posterior ciliary artery that course along the surface of the optic nerve sheath and supplies the optic nerve and the choroid is critical to prevent ischemia, especially the ischemic optic neuropathy or choroidal infarction. So these things are very, very important, and we have to notice and we have to understand this. making windows or the series of the slit in the optic nerve sheath just behind the globe to release the CSF pressure. It is depend upon the choice of the surgeon, and the different surgeons have different experience. But as you know, the medial transconjunctival approach, which I told you, which is the most popular, about 60% people are using that approach, and the medial transconjunctival approach is the most widely used approach for exposure and fenestration of the optic nerve. It was first described in 1973 by Galbraith and Sullivan. And one significant benefit of this approach is that it offers quick access to the retroorbital optic nerve without creating an incision in the skin, and however it requires this insertion of the medial rectus muscle that can result in post-operative strabismus or diplopia. After the establishment of general anesthesia and patient preparation, a lid speculum is placed, and the limbal periotomy is made nasally, and and dissection is performed down to the bare sclera, where the medial rectus muscle is identified, and the medial rectus muscle is isolated with muscle hook and secured with the 6 or double arm polyglycatine at the insertion, and the muscle is transected from the global anterior to the suture, and the traction suture may be passed through the muscle stem at the insertion so that the globe may be abducted for enhanced exposure, and continuous attention to the pupil size and the reaction to the light is critical in a monitoring of the optic nerve integrity throughout the rest of the procedure. Gentle blunt dissection is carried down along the medial aspect of the globe and into the interconal space using the surgeon's orbital retractor for choice. Once the optic nerve is visualized, the operating microscope is brought over the field, and a fine long forceps such as the myringotomy or bayonet, this is used to grasp the optic nerve sheath. A sharp scissors are used to incise the optic nerve sheath at least 1 millimeter away from the insertion of the nerve, and alternatively a long fine cutting instrument such as the super sharp parasynthesis knife may be used to make the first cut. A gush of CSF indicate successful full thickness penetration of the sheath. Additional cut with the scissors are made until a window of tissue is excised and removed. All orbital instruments are removed, and the medial rectus muscle is reattached at its insertion, and the hemostasis should be confirmed, and the conjunctiva is closed with the surgeon's suture of preference. And Ferries and Lai described an alternative to the procedure in 2012. There the approach entails the transconjunctival approach to the medial interconal space, and however instead of detaching the medial rectus muscle, the muscle and the superior rectus are engaged on the bridal suture and used to rotate the globe inferiorly and temporally, and the orbit is then entered with the orbital retractor in the space between these muscles to access and fenestrate the optic nerve as described above. So these are some advancement in that, but the other technique I want to mention in front of you is the superomedially lid crease incision. The Pelton and Patel described this surgical approach in 2001. Historically, it was found wide utilization by orbital surgeon for access to the medial interconal space for removal of intraorbital lesion by creating an incision in a crease of the upper eyelid, and the scar is well hidden and is appeal of some patient for cosmetic consideration, and it is favored by some orbital surgeons because it can be performed more quickly than the classic medial transconjunctival approach, affords a direct angle of approach to the optic nerve, and does not require disinsertion of any of extraocular muscle. Additionally, an operative microscope is usually unnecessary due to the more direct approach to the nerve as compared to the medial orbitotomy approach, and the dissection takes place medial to the levator aponeurosis and the optic nerve, and as such there is a little danger of ptosis but the ciliary ganglion injury or the strabismus. But the constraint factor with this approach is the increased distance from the incision site to the optic nerve, and it is relatively more technically challenging to perform. In this, the technique is like that the lid crease is marked and the local anesthetic with the epinephrine is injected subcutaneously. After establishment of the general anesthesia, the patient's preparation and incision is made through the medial 1/2 or the 2/3 of the crease over the previously made marking, and the sharp dissection is carried through the orbicularis muscle, orbicularis oculi muscle, and the septum, either with cutting cautery or the Westcott scissors. The nasal and the central periaponeurotic fat pots are identified, and careful blunt dissection is performed between them into the orbit between the levator aponeurosis and the superior oblique muscle. Dissection is carried out inferiorly and posteriorly towards the back of the globe in the loose areolar orbital fat until the optic nerve is strummed and then visualized. Continuous attention to pupil size and reaction to light is critical for the monitoring of the optic nerve intrinsically throughout the rest of the procedure. Neurosurgical quaternoid may then be used to pack around the nerve, and operating microscope may be brought over the field at this point per surgeon preference, or loop may be utilized for magnification. A fine long forceps such as the myringotomy or bayonet is used to grasp the optic nerve sheath, and the incision is then made in the optic nerve sheath at least 1 millimeter away from the insertion of the nerve, using the surgeon's instrument of choice, taking care to avoid contact with the nerve itself. A gush of a CSF indicates successful thickness penetration of the sheath, and additional cut with the scissors are made until the window of tissue is excised and removed, and hemostasis is confirmed, and all instruments are removed from the orbit, and skin is closed with a 6-soap plain gut suture or the suture of choice. Lateral orbitotomy approach. This technique was first described in use for the optic nerve sheath fenestration in 1872 by De Wacker, and then subsequently in 1988 by Tess et al. and the Patel and Anderson, who performed the lateral approach without removal of the lateral orbital wall, and the benefit include an excellent perpendicular view of optic nerve without the requirement of muscle disinsertion. However, it can potentially result in increased operating time and injury to the ciliary ganglion, and additional external incision is required. The technique, definitely I want to mention this also. After the establishment of the general anesthesia, patient preparation, the lateral canthotomy with cantholysis is performed, and the traction suture is placed through the cut edge of the upper eyelid and the lid margin, and the process is repeated for the lower eyelid. Finally, the third traction suture can be placed at the insertion of the lateral rectus muscle. The globe is added using the traction suture. The conjunctiva is incised with Westcott scissors as far laterally as possible, taking care not to injure the lacrimal gland or lateral rectus muscle. Bailey blunt dissection with a small malleable is carried out without the lacrimal gland and the lateral rectus muscle, directed posterior to the globe, and it is often necessary to cut through any intermuscular septa that may be present before the interconal compartment become accessible. Blunt dissection is continued through the intraconal fat until the optic nerve is identified. Neurosurgical cottonoid may then be used to pack around the nerve as focus shift to the optic nerve. An operating microscope may be brought over the field at this point. Per surgeon preference, a loop may be utilized for the magnification. A fine long forceps such as myringotomy or bayonet is used to grasp the optic nerve sheath. An incision is then made in the optic nerve sheath at least 1 millimeter away from the incision of the nerve using the surgeon's instrument of choice, taking care to avoid contact with the nerve itself. A gush of CSF indicates successful thickness penetration of the sheath. Additional cut with the seizure are made until the window of sheath is excised and removed. Hemostasis is confirmed, and canthotomy and the skin are closed using the surgeon's preferred technique. A revised lateral approach is another technique that obviates the need to transverse the interconal fat by following the curve of the globe while the posterior dissection. In this way, it is similar to the medial transconjunctival approach but take advantage of the additional space afforded by the anatomy. Complication, as you know, with the outcome and the complication of the optic nerve sheath fenestration is most commonly performed in the setting of the idiopathic intracranial hypertension. Therefore, most of the data published on postoperative complication and outcome are in clinical context. There are the variety of reported complications, most of which are the transient and minor, and there is no published comparison of outcome and complication between different techniques of the optic nerve sheath fenestration. In 2017, one report looked at the optic nerve sheath fenestration complication and associated with the cost of the surgical procedure of idiopathic intracranial hypertension. There was roughly 500 optic nerve sheath fenestration procedure performed on about 350 patients with an average follow-up time of roughly 25 months, and the medial approach was performed mostly and roughly and a lateral approach applied only in 50 patients and combined approach in 3 patients. They concluded that the optic nerve sheath fenestration could reduce papilla edema and improve vision, and disc swelling improved about in 95% of patients, and visual acuity improved in 70%, and the visual field showed improvement in 65% of patients. However, the optic nerve sheath fenestration initially improving. In another study, 95% of the patients who underwent optic nerve sheath fenestration had improved visual acuity and visual field with no reported intraoperative complication. So, and that mean follow-up about the 20 months. So, we have both the studies and we can understand how much the complication possibility, and definitely every procedure has some complications, and we cannot deny, but there is a potential complication I want to introduce in front of you, such as the conjunctiva and the sclera, chemosis, globe perforation, conjunctival bleeding, cornea, corneal Dillon or corneal ulceration, anterior chamber acute angle closure glaucoma, microhyphemia, or you can say the tonic pupil branch retinal artery occlusion or central retinal artery occlusion or choroidal ischemia infarction or optic nerve cyst, pseudomeningocele, traumatic optic neuropathy, ptosis, mydriasis, diplopia, hemorrhage, hematoma, infection, orbital apex syndrome, strabismus, diplopia. These all are the possibilities of the complication, and these kind of complication can happen with that kind of the surgeries. And these surgeries definitely we are not doing for routine, definitely the proper indication, and we are following the indication, and according to the indication we have to perform and then do it. Optic nerve sheath fenestration is a surgical procedure employed to prevent visual loss from the papillar edema in the setting of the increased intracranial pressure. It is most commonly used in the prevention of the visual loss from papillar edema in idiopathic intracranial hypertension, but has other indication reported in literature. There are three major approaches to exposing the optic nerve for decompression, with medial transconjunctival approach being the most common, and stability or improvement in the visual function is seen in the majority of patients, and in reduction of the papillar edema grade, and the rate of the major complication is relatively low, and the many minor complications such as the ptosis and diplopia are usually transient and then corrected with the with the time. And the further studies have needed to evaluate other indications for the optic nerve sheath fenestration and to compare outcome between the different surgical approaches. Comparison study of the optic nerve sheath fenestration CSF diversion procedure for the treatment of the visual compromise from the papillar edema will also be beneficial, and a major study is currently in the planning stage. So that's all from me for this a good topic, I think, optic nerve sheath fenestration. I hope you will like it. If you like it, share it, subscribe it, and support us. Thank you so much. See you in again with another video.